For this next panel, Scaling Impact, Bridging Access and Breakthroughs, I'd like to introduce our moderator. He is a lecturer at UCLA Anderson School of Management. He's a triple Bruin, and he is my professor every Monday evening, Omid Toloui.
Yeah, thank you so much. Awesome. Well, it's great to be with you all. We're going to be talking about one of my favorite topics, which is scaling. We talk so much about technology in healthcare. We're hearing about AI, about the latest innovations. But innovation is really only innovative if it leads to impact at scale. And sometimes it's not necessarily the best technology or the best founding team that scales their solution in healthcare. Sometimes it's the company that's the keenest, that understands the healthcare system well enough to be able to navigate the healthcare system and get their solution adopted. So we're very lucky. We have a payer, we have a life sciences company, we have one of the largest provider organizations in California, and we have a startup. So we have, it's almost like a joke, like the payer, a startup, and a life science company walk into a bar. But we're going to have we have like 2/3 of the healthcare system represented on the panel, and hopefully we're going to have a great discussion. So what I want to do first is hand it over to our panelists. I'm going to ask you to introduce yourself, and then give me a little bit about what is the biggest obstacle that you've faced when trying to scale innovations in healthcare. We'll start here.
Hi, I'm Deborah. I'm a director in transformation operations at Blue Shield of California. Super excited that there is payer representation up here. We are a big distribution channel for most health tech. So biggest challenge. I think it's exactly what you just said, is it's not always the best that gets scaled and gets traction. A lot of it is built on relationships, it's persistence. The sales cycle is very long with payers. And it's about being there at the right time when the leadership is ready to invest in that space.
Awesome.
Excellent. I'm Aubrey Kelly, founder and CEO of Rabble Health. I left an industry job. I worked at Amgen for 14 years, and I started Rabble Health following my son's pediatric cancer journey. So he's a survivor. I got to drop him off at 4th grade today. He's a bone marrow transplant survivor. But one of the gaps that I saw was that the tools and technology that are available for us as consumers, us as patients, and us as caregivers really aren't optimized for us as individuals. And so the biggest opportunity that we have, I think, as a startup is to scale, but scale in the right direction. It is not good enough just to push technology onto populations, particularly marginalized populations that haven't been co-created with them. And so as we talk about AI, as we talk about tools and technology, I like to say that we got to put kind of patient support at the forefront of recognizing who we're creating impact for, and get really hungry about that real world impact data that we want to have. And so, yes, it's about steering the right direction, bringing in all the tools and capabilities, but ensuring that we don't lose focus on that co-creation step beforehand.
Awesome. Co-creation, love it.
Hi, everyone. Seth, Clancy. I'm with Edwards Lifesciences. It's a global med tech company in Irvine, so just south. I don't see the 07, but go Bruins. I was part of that cohort as well. I do a lot in the med tech space, and we really focus on structural heart disease. So I would say, from my perspective, one of the biggest obstacles and challenges we face right now is staffing and capacity to scale in our systems. So I can tell you that my team purchases lots of different data sets to track the journey from a patient being diagnosed with things like severe aortic stenosis in the United States all the way through to treatment. And right now, the average is about 162 days nationwide from diagnosis to treatment, 6 months. Now, at 30 days, the mortality time on the wait list is about 4%. So we have a massive challenge with a system flooded with far more demand than we're adding capacity to meet that growing demand. So when we think about scaling innovation, we often think about technology and assume that just because we have the technology, it's going to solve the problem. You really have to be thinking about how do you couple technology with resources, operations, support, workflow to ensure that you actually have the capacity, both physical and human, to deliver on the promise of that technology. And it's something that I think is at a crisis point in the country and made far worse by the COVID pandemic. And we still haven't sort of transcended beyond that. So in my opinion, this is a major challenge we're grappling with.
Thanks, Seth.
Good. I'm Ryan from Hoag Hospital System in Orange County. We're a 2-hospital system with 400 physicians in our medical group, and then about 1,000 other physicians who are in the system. And I have loved being at Hoag. I've been there 3 months. We're an $11 billion system with really great high quality in terms of programs. And also we have the last physician-owned hospital in the United States, which is the Hoag Orthopedic Institute. And so when I think about that and how that's worked out to create value, I think about the alignment that's needed for technology. And I kind of picture a 20-circle Venn diagram. And if implementation is in the middle of technology, you have to get everybody aligned from finance, from the CFO, to physicians believing in the technology, to the operational implementation. So I think it's that alignment of technology that is the biggest challenge when we're working with new companies, and we desperately need new technology in our health system.
So, all really good insights. I might come back to getting your opinions on how we go about overcoming some of those obstacles, but I want to jump to you, Seth. One of the things I like to talk about is shiny hammer syndrome. I think it's rampant in healthcare. What does that mean? It means that in healthcare, we are quick to fall in love with the shiny hammer. Cool new technology, cool new service, cool new LLM, right? And we fall in love with the solution and we forget to really focus on the problem that we're trying to solve. I'm sure in your space, there's a lot of shiny hammers that you're encountering. How do you make sure that you're not falling in love with the shiny hammer and you're really focusing on like the right innovations?
Yeah, I think one filter is be really leery of solutions in search of a problem, right? You start with the problem, not the solution. And from our perspective, we try to think about large unmet clinical need. You develop the technologies to address that rather than starting with a technology that's cool and trying to find a problem to solve through that. We take a step further in obviously trying to be good stewards within a healthcare infrastructure that's trying to achieve a triple aim objective, right? So you want to start with large, important, unmet clinical need, and then you're looking for technologies that it can improve population level outcomes, health outcomes that matter most to patients with that particular condition. Are you improving the care experience for those afflicted with the condition? And then finally, are you able to do it affordably? When you can deliver on that sort of triple win, then I think you've sort of gone through starting from meaningful unmet need, a technology that solves for that meaningful unmet need, and then it's sort of connected to broader objectives that all of us are trying to get behind.
Awesome. Similar question for you, Deb. You're working at one of the largest payers in California. California is a big state. Lots of different, I loved, Kesar was talking about how diverse the United States, diverse California is, especially Los Angeles. You're in many different markets. So different individuals, different backgrounds, different socioeconomic issues or challenges. How do you all kind of figure out when the startups are knocking at your door, because you are the holy grail, like getting paid by a payer is ultimately the holy grail. How do you go about figuring out, what are the startups that we're going to work with that are ultimately going to be able to get us the results that we're looking for?
Yeah, and I think we talked a little bit about validation and what are the endpoints that we're looking for. And so the way a payer works is we've got two to three main financial mechanisms. We have cost of healthcare, which is our claims cost of what we're paying when patients or our members are going to get healthcare services. Anything that you can do that reduces that in a meaningful way is going to be attractive for us. And then we have the administrative side, which is all of the workflow and the overhead that goes along with that, or what we pay to distribute, commissions, things like that. So if you can also make a dent there, it's also very attractive. And then lastly, the revenue streams that people are maybe less familiar with, which is your Medicare Stars revenue, or your risk adjustment, which are essentially quality revenue payments. So as long as you align to some of those, you're going to get through the door. Sometimes there's always, the heyday of our point solutions in the employer market, it may be behind us right now with the economy, but that was another way. If our customers, if we're selling to large employers offering insurance to their employees, if you sold a culture of health that was meaningful, then they would put pressure on us to then go find partners where we could deliver a product that was what they wanted.
Yeah, I love that you touched on the administrative elements as well. There's a lot of administration that happens in healthcare. Sometimes that's not the stuff that gets attention. I want to go back to kind of this concept of obstacles. This is questions for the panel. We have a lot of health tech entrepreneurs in the audience, folks and in different startups. There's a lot of points of collaboration and friction, should we say, in the American healthcare system. And sometimes those are a little bit difficult to navigate. What advice would you give them in terms of how to go about navigating those points of friction or even those points of collaboration?
I can maybe start. Yeah. We've taken a very methodical approach around defining what our strategy is. And I think, what's right for patients may or may not be right for payers, may or may not be right for a health system, may or may not be right for a pharma. And if you're in a health tech space and you have a consumer-facing app, your logical business model is a B2B2C, unless you're going straight to consumers, wherein you're cutting off a bunch of people that aren't able to pay for your app. And we've got the 4 Ps, right, in health tech, and you got to be persistent and figure out what that is. But either you're paying into pharma, you're paying into plans, you're paying into patients, or you're paying into providers, or you're selling into providers. And you got to figure out how you're going to pitch and create value for those entities, because it's not good enough just to say, I've got this phenomenal app and we create tremendous value and we have all these consumers and you don't know how to monetize it. For us, I came from pharma and that was kind of our hunch. But for us, we're going after pharma and we're going after consumer brand marketers, and 20% of drug revenue is spent on sales and marketing. And the fact of the matter is that it's not working, right? It takes too long to get diagnosed with the right diagnosis. It takes too long to get the right treatment. And it takes too long to access services that address social determinants of health to help us keep on our treatment plan. So we're pitching into pharma consumer brand marketers and saying, we're an alternative to how much you're spending on ads, how much you're spending on single-use websites, how much you're spending on commercials. Because at the end of the day, you want to ensure that the right patient is asking the right questions at the right time. And we have an alternative to give you a better understanding and better peace of mind that your spend is going towards activating patients. But like that piece, you have to figure out before you put in the engine around scaling, right? And so I think it's a really tough space to be in. And it's a tough, code to crack, but it's super worth it, because at the end of the day, we get to make money. We get to have tremendous impact for individuals. And I would just say that you need to pull in a lot of advisors and a lot of people that have expertise in different areas so that you can learn and really understand what it takes to scale.
Awesome. Seth, Ryan, want to take a crack at it?
As you know and appreciate, the healthcare ecosystem is incredibly diverse. Generally speaking, most of those stakeholders are well-meaning. Everybody's here to try to advance this patient mission of improving lives, improving health span. I think where the challenge and rub emerges is around misaligned incentives, right? Which you heard about. What matters to a payer may be a little bit different from a provider, which is different from a patient and different from a life sciences company. I think what you're looking for is to try to find those win-wins that align the various stakeholders around a common goal. Okay, the more you can helicopter up and talk about how do we compete on the patient outcomes that really matter to the patients afflicted with a particular disease. And if everyone can wrap their arms around a common goal of advancing towards better outcomes and the outcomes that matter, not just meaningless ones, then hopefully you can get that alignment that's elusive across the various stakeholder set that's involved. But where I typically see things fall off is, again, when you have these perverse incentives that can't be overcome. So be thoughtful around not just presenting the types of opportunities that matter to you, but putting your hat or lens on from a broader perspective and ensuring that these are things that all of the stakeholders can get behind and align on.
I just want to double click on that. I think if you need a decoder ring for healthcare, one of those decoder rings is something that you said, which is understanding the incentives, right? If you can just understand what's in it for that player in the healthcare marketplace, you can really start to decode a lot of what's going on in healthcare. And I wanted to double click on that because I think it's such an important point. Ryan?
Yeah, I think some real life examples of exactly what Seth is talking about is if you look at things like ambient AI for physicians, where it's just an easy win because, they can save time dictating, they can see more patients. And for them, it's an easy win. They can easily implement it. They usually fall in love with it. And the cost is such that there's a strong return on investment. In the early days of remote monitoring, companies would approach us and they would say, hey, remote monitoring is a win, right? Patients get better care. You get paid by Medicare. And, everything looks great, right? And so just go implement it. And I think about some of those lessons, which were, does it actually provide return on investment for a managed population? So again, aligned incentives. If you have a large managed population, Medicare Advantage, et cetera, you're not going to be paid fee for service for that technology. So it wasn't a value proposition for us to say, hey, you're going to get paid for every patient. And does it save physicians time? Physicians have to present the technology to their patients, get their patients buy-in. And so did it really move forward as quickly as we thought? Absolutely not. And so I think it's those real-life operational implementation of aligned incentives that mean so much to us as a healthcare system. And, one of my favorite quotes is by Upton Sinclair that you can't teach someone to understand that which they're paid not to understand. Mm-hmm. And so physician compensation models and things that align with the technology you're going to implement have to be considered. So if you can understand that piece, like Omid said, and look at what is driving the revenue or the value for the system, and then also be willing to go at risk with systems when you're implementing technology, have skin in the game to say, hey, if you don't get paid or if you aren't able to implement in time because of us, we'll go in on it with you. So that's some of what I've learned.
Ryan, that was awesome. I think your MBA professors would be happy. You managed to do a case study in like 2 minutes. That was great.
Real life pain.
Yeah.
Can I defend my answer? So I just also wanted to add, so I talked a bunch about the financials, but that's just a way to look at it. The outcomes are also as valuable. So the way that you get your claims costs down is to focus on making people well, right? Or making sure they're getting the access to care that is hard to get, especially in California, or making sure your underserved populations are getting services that they need and meet them where they are. So it's not just like, okay, I'm looking for my bottom line. We are a non-for-profit plan in California. So it really is more shared and more common. I like the idea of like zooming up and seeing exactly what that looks like and why the incentives are the same, even if the financials pencil out differently on our balance sheet.
Yeah, and I think the beauty of healthcare is when you have really good outcomes, oftentimes, more often than not, it leads to a positive ROI. And that's part of why I love the business of healthcare, why I'm fascinated by it. Aubrey, you're the lone startup on the stage. Okay, I like when I think about startups in healthcare, I think about the game that I like playing as a kid on Nintendo, which is The Legend of Zelda. You're like that little elf with the large, sword going through this world and trying to get to scale. Yep. Look, if we're thinking about a startup, how can we help erase some of those monsters or those challenges to make it easier for companies like yours that really want to do good work to scale more quickly?
It's a great question. I think there's when I started, I was like, oh, I've got it set. I've already got some consulting gigs. Like, I appreciate that, typical startups hit their hockey stick at year 7 to 10, but I'm an Anderson grad. We're going to accelerate this. and I share that, and I've been humbled because there are some critical lessons along the way about you starting a company. And I actually, maybe I'll just ask the audience, how many of you are actually either just started or planning on start your own company? So
decent number.
It's amazing. Just keep going, right? The game for a startup is not to die. I was telling you, that's it. It's just not to die. And the fact that we've been at this over 4 years, we still have a website, and I'm like, that's something, right? And so, I I raised a fair amount. I raised just over $1 million on friends and family, which I'm very fortunate to have those kind of friends and family. And we are as scrappy as possible. And we're about to open up our seed round, later this year, because we're post revenue and we've got, the homework that we've done now in terms of understanding how to scale. And it is a wild ride. I'll just share, but just don't die. And there are a lot of, there's a tremendous network from Anderson to kind of help you lean in and understand what are some of your alternatives. The previous panel talked about non-dilutive funding and dilutive funding, and just have that thirst for learning, because I focus on entrepreneurship at Anderson. I did the Nat Business Competition, and there are things that you learn and you get to deconstruct and kind of decode what becomes a business. But you also have to play every single hat. And you have to learn, if you're in health tech, you learn Figma and how to be your own designer, and you learn how to leverage AI. And I think the barrier for non-tech founders to actually start becoming tech founders is a lot. We have the means now to be able to be tech founders, and there aren't as many hurdles for that to happen, which means that I think in the past, VCs were really attractive to tech-based founders because they could create the tech. Well, I think it's switching. I think it's people that understand how to drive a business and drive that business model. They can grow into being that kind of tech-enabled founder, but just my biggest word of advice is just don't die. Try it. Take that leap. There, you might not see the net, but don't die.
Yeah, that's good advice if you're playing a video game too. You don't want your character to die. I was on a panel just a couple days ago, and they concluded that, and they said, what is one piece of advice that you have for individuals? It was entering into the Medicaid space, to innovate in Medicaid. Very similar to what you said. The one word I said was grit. Yeah. You need to have a lot of grit, because the obstacles are going to be there, and you have to keep focused on that North Star of what you're trying to build. So the risk of, I'm going to extend the analogy, at the risk of losing half the class that probably didn't grow up playing Nintendo, Ryan, trying to innovate or scale or take a technology and scale within a large provider organization is kind of like Mike Tyson's Punch-Out. You're that little guy, there's lots of different bosses that you have to kind of get through in order to, ultimately get your technology adopted by providers and advanced practitioners. What's the best way to handle those obstacles to scale a solution within a provider organization like yours?
Yeah, Mike Tyson Punch-Out. Yeah, that is truly like getting something implemented at a health system. From my perspective, yeah, you've got that Venn diagram again. And usually if you want to implement a new technology, you have to get physician buy-in. Kind of start there, right? If physicians and advanced practitioners don't believe in it, forget it. That's kind of step one. Once you get that in place, you start to look at the financials of it. You look at it, and the physicians are really going to say whether it drives quality. You look at the financial approval. If there's no reimbursement available from payers or the federal government, you have to bridge that with philanthropy, or the company has to kind of prove it out with you or provide some funding. And so really, between the finance and the physicians and that layer of approval, that becomes kind of the first challenge, right, for a startup. From there, it really becomes how can you get busy clinicians to implement, and you have to work with teams and medical assistants or nursing to get something implemented. And there's just, it's a lot slower than I think you'd all like, right? So I think anything you can do, obviously, to help speed that up from, providing great business cases, providing something that both the CFO and physicians can agree on, having strong clinician support for your companies if you're going to go into a health system. These are all the layers that you have to get through Mike Tyson's Punch-Out, because I've seen things die at the approval level. I've seen things die at the implementation level. So you've got to get that buy-in cleared from the beginning. And once you do it, you can be very, very successful. And I've seen that too. So I don't know if that's helpful from a real life example.
Awesome. I want to ask one last question for the panel, and then hopefully there's some burning questions in the audience, and we'll have more time to do that. But one, we've talked about innovations and scaling innovations, and at the risk of potentially falling in love with the solution before we fall in love with the problem, I'd love to ask you, what is one innovation it's a two-part question. So what is one innovation that you're particularly excited about? And if you say AI, you better have like a good application for AI. AI doesn't count as an answer. And the second thing is, if you're reading the Wall Street Journal in 10 years and they have like a big, 3-page or 4-page article about healthcare innovation and the state of healthcare innovation, looking back 10 years, what is that one headline you want to see in the Wall Street Journal about healthcare innovation in 10 years? Who wants to go first? Very orderly, left to right. Okay. Or right to left.
So the first part is what innovation. So I think I'll go old school and say I think that we have redefined health in the past probably 5 to 10 years, and it's getting more accepted and it is getting reimbursed. So what I'm talking about is putting your railings on your home so that you can exit your house if you're in a wheelchair, paying for non-emergent medical transportation to bring you to dialysis because you can't drive. Like that is now a covered healthcare service. So I think that, especially in California, it's pushing in that direction. It creates a lot of other challenges because that's not a traditional claim that we now have to process. But I think it's accepting and now trying to institutionalize that healthcare is not just in clinic. Second part.
In 10 years. Yeah.
Oh, that
headline.
We have bent the cost curve. It is on, at least flat, if not on the way down.
For me, it's not necessarily health tech innovation. And some of you, I was talking about at lunch. How many of you know the app Duolingo? Mm-hmm. Okay, awesome. So we are getting smarter in the context of what constitutes behavioral nudges, right? So health tech, Duolingo has been written up in terms of being a premier app in terms of behavioral nudges. We are getting smarter around what helps activation of individuals of all populations, not just of people that look like me, of different communities, et cetera. And we can apply that. We can take some of those lessons from tech that's working for consumer-driven activation, consumer-driven enablement, and start applying that in our health tech sector, which is a little bit behind the curve. In my case, and in our case, there's 12.5 million people that have uncontrolled asthma. That translates to 3 times as much cost in terms of avoidable hospitalizations, et cetera. That's our product market fit. We're actually solving for that piece. And so a lot of the design that went into kind of our app, My Rabble, is based off of a lot of those other apps in terms of what's working outside of health tech and taking that in. So I get really excited about that piece. The biggest headline that I would like to see is that we're able to, as Americans, we are able to see more people live longer and with a higher quality of care because we're starting to work together more optimally. And I think that right now we're a little bit divisive. I think it might be a little bit of a rocky kind of first half of 2025 until we kind of let the dust settle and we figure out kind of what is that role between government, between health systems, between health plans, between patients, and between industry, and how we're all working together. I was on the crew team in college, and I just feel like our entire health sector is really not rowing in unison right now. And so I hope in 10 years we'll be able to see that the factor of us working more in unison translates to better patient outcomes.
Well, I'm going to go the AI route, but I'll try to.
All right. Just qualify it. Yeah.
When I was a student here at UCLA in the mid-2000s, if you were a patient that had aortic stenosis at that time, your only option for a life-saving treatment was open heart surgery. Fast forward to today. We have technological solutions that allow you to have a percutaneous procedure to replace your heart valve. You can be awake for that procedure, and you can be discharged next day, and you circumvent 6 months of recovery through open heart surgery. Remarkable advancement that has been paradigm shifting in cardiology. Huge deal. We still only treat 13 out of 100 patients with AS in this country. So as I think about the next 10 years, technology isn't going to get us to 50 out of 100 treated. We're going to have AI-enabled workflow and disease identification models that more easily get patients from upstream all the way to the point of care. I work closely with a surgeon at Robert Wood Johnson named Mark Russo. Mark Russo's quote is that today, the hardest part of a TAVR, a transcatheter aortic valve replacement procedure, is getting the patient on the table in the first place. It's not the procedure. Procedure's easy. It's getting the patient there. So I want to see in 10 years an AI-enabled workflow model that gets all of those patients currently slipping through the cracks to timely intervention that can be life-saving. So my headline would be AI workflow helps more structural heart patients to live longer and healthier lives.
Awesome. For a second, I thought we were going with that as you were going to be happier because you have to train the AI and not the heart surgeon. But I know you're sitting next to a provider, so I'm glad you didn't go that way. Yeah.
Thank you. Yes. I would have two headlines: that we've solved physician and nursing burnout, through AI, right? And we do have some technology even now that's helping them. And then that we could have patients treated successfully at home. Just having had a death in the family and watching that member of the family, she just wanted to go home. And if we can truly introduce hospital care at home, and it will be paid for by the payers in a way that makes sense, that's going to benefit everybody. It's going to reduce burnout, and I would love to see that headline someday.
Well, with that, I hope we can all, everyone in this room, including the people on stage, work towards making that vision a reality, work together to make that vision a reality. Because I was inspired by those headlines, and I hope to live to see those headlines come true one day. All right, I think we have a little bit of time for Q&A from the audience. I see a hand over here in the front.
Hello, thank you so much for being on this panel. It's been very enlightening. As someone who's working on trying to come up with the medical device through the correct way, right? Finding an unmet clinical need, and then from there, innovating around that. One thing that we do have in our mind is the question that came up, like, who will pay for it / who will want to take it upon themselves to take the idea further, right? If our exit strategy is hopefully a big multinational comes and picks us up. With that, you guys did talk about aligning incentives. From my perspective, it's somewhat a little bit difficult to know what direction one of your companies might be going into, right? And then at the same time, designing with the end user in mind, right? So for Hoag, I know they did a really great job of bringing in, virtual reality to your patients. I thought that was, you guys used a really cool technology, but brought it in kind of in-house, right? So you guys have an innovation center that said, let's try this for patient recovery. I know for Edwards, you guys are focusing on like the TAVR and trying to get in more patients who have aortic stenosis to use a TAVR procedure by partnering up with doctors who can funnel in their patients. And I know there's technology around looking at echoes to try and detect aortic stenosis ahead of time, right? And then I know for Blue Cross Blue Shield, you guys are now one of the, for California, the ones who do insurance for those who don't necessarily have for public insurance. So just trying to figure out, how do I know from my perspective what incentives align with you guys so that we know that when we are developing, we have somebody on the other end who's going to say like, yes, I'm going to take that upon myself to take that further.
So I think I like to say follow the regulation and the payments. It's going to be easier to get traction if something is already there's a payment model we can implement at this stage. So check out, what's incentivized, HEDIS measures or other kind of quality areas. Even health equity is something that we're incentivized to do. So if you look at where the regulators are focusing and requiring payers to make changes, that's where you can push innovation more easily. And that might be more ubiquitous. Otherwise, it's just the hustle of relationships.
I can jump in. I mean, I think the single most important thing when you're doing product development is applying empathy. There's some folks from my team here that are probably sick of hearing me say that. And empathy means really understanding the lived experiences of the person that you're designing for. Fundamentally, that's the single most important thing. And everything that you talked about, I think, kind of ripples out from there. So if you have a solution that can ultimately have some kind of significant impact. The next question is, what is that impact that you can generate, right? And who is going to benefit from that impact? Is it just the provider? Is it the patient? Is it the patient and the payer? And then from there, I think you can start to understand, okay, so then who has an incentive to implement this technology, to fund this technology, and how do they go about funding it? Is it a quality program that it's going to support? Is there a CPT code that you can bill for? Anything from there, I think you can then start to piece together what your business plan looks like. Yeah, great question.
Yeah, maybe I'll just also add that within the life sciences field in particular, you can also double click on if you're wanting to put your technology out there as a target for acquisition. Across medtech, you have different strategies for different companies. Some have a much more internal R&D strategy where a lot of the organic innovation is going to occur through spending on R&D internally. Other companies are habitual acquisition entities, and that's how they innovate. And so you want to be mindful of which of the two strategies is employed because you may not align with that value proposition. And so that's just something to be aware of going in. If again, the idea is being a target for acquisition and being part of a larger life sciences ecosystem, the other thing you want to be really mindful of is the incentives, but the milestones that have to be hit to execute on certain acquisition strategies. It's not enough now, in most instances, to develop the technology. You've got to sign up for getting to a certain stage within the regulatory pathway. That may mean FDA approval, or it may mean clinical trial enrollment in phase 3 clinical trials. I mean, there are various ways to structure these, but it's not as simple as just bringing the technology to proof of concept. There are going to be lots of different ways to structure those deals. And I would be thoughtful and intentional around where you want to draw a line in the sand and say, this is the milestone we can commit to developing that technology to.
Great responses from the panel. Other questions? I see.
Yeah, thank you all very much for participating in the panel. I also work at Edwards Lifesciences, so I'll connect with Seth later. But I have a question because right now I'm taking a course and we're really focusing on value-based care and how that has been impacting sort of the healthcare landscape. And since we have a payer and we have a healthcare system, and I understand Edwards products very well, so that's the same kind of question that we see is we have a great product, we have a huge unmet population need. How can we encourage, for example, Hoag healthcare system to build more cath labs so we can get in more patients, because our procedure is very profitable. It's quick, great outcomes. And for the payer side, what kind of things are you looking for in order to pay for those procedures, understanding that you're preventing future hospitalizations and expensive follow-up care?
Sure.
We're going to get like a bundle going here between Blue Shield and Hoag.
Blue Shield, Hoag bundle. We're very expensive at Hoag, so yeah, that'd be good. I think it's a great question, and it depends on to the extent to which your system has value-based care or has desire to do value-based care. My old system was very much entrenched in trying to improve quality and value through the primary care group, to the extent that we even approached private equity and try to enter to get the technology that would drive value, right? Because we had a lot of managed lives. A lot of our revenue was dependent on that value-based care. At Hoag, there really isn't even a thought about it. We'd like to build more cath labs. We understand the reimbursement there. And it's a double win, right? Because you get the reimbursement, it actually helps the health system survive, and the patients benefit. It prevents long-term hospitalizations. So both in a fee-for-service and value-based world, it works. So we're all in. And if you can get Blue Shield to pay us well, we're good. Yeah.
And I would say I'm not on the contracting side of the company, but we are pushing for value-based care, and our CEO was very big, like any capitated model is one of the bigger HMO plans, ACOs, and really trying to get most of our payments off of fee-for-service. But there is a two-part equation. And so what I would say is how predictable can you get cost? What does the upside and downside look like? Like, what's the variation? Because I think both parties need to know what, if we were to do a bundle, what's in that bundle and what's the variation off of that, so we can make decisions about whether it makes sense.
Other questions? See one in the front and one in the back.
Thank you. So my name is Reza. I'm an ER physician here at UCLA. And something, Ryan, that you spoke about regarding the second headline, which was you'd like to see more at-home care. So would I, because then that would decrowd our ERs. But one of the things that I notice about a lot of the ways that we try to decrowd the ER, sending people to urgent cares or having more primary care office hours, there's a lot of deferment of risk back to the ER. A nursing hotline gets a call about chest pain. They're like, no, go get your EKG at the ER. And then this person's waiting for 12 and a half hours for me to tell them that it's just GI upset and they need to take Pepto. And so I'm wondering how, is that one of the things that's stopping it? Is it just payment that's stopping at-home care? Or is it also this constant deferment of risk back to the larger mothership healthcare, like hospital system?
I think it's both. I mean, it's a really crucial question. And I mean, I think that, the pushing of that risk back and forth is part of it. I think it truly is the aligned incentives. If we're paid $3,000 a day for a patient to be in the hospital, what does that payment look like at home, right? So that's the big question. In terms of can you actually extend the care in the home to make it equal to that of the hospital? That's a big question in people's minds. So I think that's another thing. In terms of the systems that go around the ED and around the hospital that you're talking about, I think that's part of the equation, but I really think it's more related to, can you deliver the care? Can you create the incentives to align it at home? I think when I look at your challenges, I think about broad population health work, right? And do you have the care management pieces? Do you have the infrastructure provided to you so that ED doesn't have to bear the whole burden? And that, to me, is a bigger network of care management that you have to do that may or may not involve hospital at home. Does that make sense?
I think that's I'm just going to jump in. That's a big, having tried to build those programs, it's very much about incentives. I think if the financial structure isn't incentivizing a hospital at home program, it's going to be really difficult to scale something like that. But I think all of us would rather be at home convalescing or, getting treated for some chronic condition that we have, or if we have, COPD or CHF, being treated at home. So I really hope that can scale. It's also a logistical challenge too. But I think if you have the right financial incentives, there's a lot of smart people in this room. They'll figure out how to do the logistics. But I don't think the financial incentives are quite there yet. I think there was a question in the back. I don't know if they still have a question. Yeah, there we go.
Hi, I'm Edvin. My question goes for Aubrey specifically. I know that in healthcare, it's getting distribution solved is probably very tricky because as you mentioned, sales cycles are long. How did you start thinking about that from the beginning? And did you ever pivot so that you can maybe try out a different distribution model for the product?
Yeah, it's a good question. So if you're in the health tech space, you're not in it just to make money, because if you were, you'd just be a tech company or fintech and you'd make a ton of money for the same amount of work. So I just want to call out, I mentioned the 4 Ps earlier. They, apart from consumers, which you're segmenting a subpopulation that is willing to pay for your tech. No offense to the providers or the payers or for those of you part, but your sales cycles are astronomical and it is so tough to get in, right? So I just want to, when we talk about persistence and grit, you have to know that you're looking at a minimum of 9 months to try to get in, try to sell, right? I'm fortunate where I had 14 years industry experience, and so I had a lot of friendlies. I was able to build up my board of advisors to also extend some of those friendlies to take a chance on us. We've been able to sell into Gilead as well as Amgen. And we've learned a lot, like just a ton. So I say that because even if you don't have kind of that deep network, someone on the previous panel said Los Angeles is just such a tremendous community of people who want to help you out. And we've got, just a diverse, skill set and a lot of people and a lot of patients and a lot of physicians that want to see you succeed. So network like crazy, but also be prepared that it's often going to be those friendlies that are going to take a chance on you so that you get to learn. And that's part of the game, right? It's a high risk, high reward. That's what startups are, right? And so it takes a while. I had someone on my board who ended up becoming on my team with tremendous experience in the health plan sector. And so I wasn't sure what our value prop was going to be or who was going to end up paying for us. But we've it's taken us a while to figure out what that business model is. And now we're clear. So now we're into that kind of scaling piece. But be open and also recognize that be along for the ride, but you're going to get traction more for the friendlies than the cold outreach, at least initially.
Do we have time for another question? One more question. All the way in the back, making you run. Yeah, good. Work off those cookies.
Hi, thank you all for coming. I have a question for Seth. So I work in regulatory affairs and medical devices. I was wondering, how does Edwards Lifesciences and some of these other major companies expedite or reduce the time frame between approval and reimbursement from CMS or some of these providers? Have you seen some of these larger companies like Edwards take advantage of the CMS FDA co-pathway? And what do you think we can do more to get these innovative treatments faster onto the market at an affordable price through insurance?
Right. So I think that's the $64,000 question is how do we accelerate, right? How do we get to market faster and do it in the right way? As one of the speakers from the prior session suggested, engage early and often. So you've got CMS, which manages the coverage and reimbursement. You've got FDA that does the approvals for PMA and 510K applications in this country. You've got to be having dialogue with both. If your issue and concern is around reimbursement, which includes both payment in terms of codes and coverage, then you got to be having the dialogue through CMS. There's lots of new pathways in the former Trump administration. We had MCIT, now we have TCIT. Who knows if we'll go back to MCIT? There's the traditional NCD pathways. Is your technology covered under existing LCD or NCD? All that landscaping needs to be done. But my biggest point of advice would be engage early and often, not when you sort of need them to do something and you need them to do it yesterday. I find that, the group there at the coverage analysis group, 35 people compared to 300 plus at FDA, they're short, they're lean, they're struggling for resources, but they want to advise, they want to engage, they don't want to be surprised by new technology, and they will generally be open to giving you suggestion on how to strategize your coverage and payment pathway.
Great. And with that said, please join me in thanking your panelists.